Hello, my name is Alexandria Hertz. I'm presenting on microscopic hematuria evaluation risk stratification, a machine learning approach coming out of Madigan Army Medical Center. For background on the topic, as most urologists know, the current AUA guideline for evaluation of asymptomatic microscopic hematuria is to base it off 1 year analysis with 3 red blood cells per high power field or higher. If you actually look at the AUA guidelines for this, the studies that were used to base this off of were fairly old, ranging from 1926 to 1982. In the 1926 value, the determination of using 3 red blood cells was actually fairly arbitrary when you go back and look at it. And it's interesting that these sort of historical articles are being used for the guidelines, given that there's been so many advances in the field between even 1982 and today. Additionally, the current guidelines account not at all for risk factors that would predispose patients to malignancy or other causes to prompt an evaluation for the microscopic hematuria. And I think of a particular import to us is that only 1% of the evaluations we perform for microscopic hematuria will result in a diagnosis of malignancy. This is also in the setting of not insignificant risk being associated with the evaluation, to include a 5 to 7% risk of urinary tract infection, radiation exposure, as well as patient anxiety related to an evaluation. So our objective with this particular project was to explore the use of machine learning to establish a predictive model for which patients would most benefit from the evaluation of microscopic hematuria. So essentially, a retrospective review of 229 consecutive patients referred to urology for evaluation of microscopic hematuria was performed. Information that was abstracted included urinalysis results, age, gender, cystoscopy, and imaging findings, as well as other relevant risk factors. So following this, the classification of dichotomous cystoscopy results, meaning were there positive cystoscopy findings, was performed using the MATLAB classification learner tool using specific predictors, which were the number of red blood cells on urinalysis, age, gender, smoking history, and radiation history as particular risk factors. We then tested 15 machine learning algorithms in the domain of decision tree, logistic regression, naive Bayes, support vector machine, and ensemble classifiers. All 15 machine learning algorithms were tested from the classification learner tool because this is the first look at evaluating a predictive modeling for this type of evaluation. And it would be difficult to determine on face value which algorithm or statistical manipulation would be best for this particular type of data set. So by running them all, we kind of helped to determine that. In terms of getting into the nitty-gritty details of machine learning for those unfamiliar with it, the different domains, decision tree versus logistic regression, are just different statistical approaches to evaluating the data broadly. So, and then following this, a 5-fold cross-validation protocol of randomly splitting the data into training and testing sets was used to evaluate this classification performance, specifically looking at sensitivity, specificity, accuracy, receiver operating characteristics, as well as positive and negative predictive value. So breaking down the 5-fold cross-validation, essentially what this means is we break it into training and testing sets. This isn't a straight 50-50 break. It's more of an 80-20. And this helps to make sure that the results aren't just a random result. This also helps to correct against overfitting and overall helps generalizability of the data, essentially making sure it's not just a fluke. So that's the purpose behind doing that. So when we look at this for our data, the best classification results were obtained specifically using the medium tree classifier, which is under the decision tree domain. This had a specificity of 90%, a sensitivity of 43%, and an area under the curve of the ROC curve of 0.77 or 77%. Additionally, the negative predictive value, which is especially important in a screening tool, which this predictive model would be, was 87%, meaning that if we were to use this predictive model as it stands now, if we said that the likelihood of having a negative result, 87% of the time that would actually be true, which is very high, especially given the numbers of the evaluations we have here. And in terms of breaking down, specifically looking at the medium tree and kind of the decision tree domain, this uses a leaf and branch model where the algorithm goes through a series of yes/no questions, leading to a final leaf, quote unquote, branch point to come up with the answer. In this case, positive evaluation or negative evaluation on cystoscopy based on all of those predictive factors we've gone over previously. This is just a table reviewing all 15 machine learning algorithms that were evaluated, broken down by domain. You can see the specificity is quite high, kind of across the board, with relatively low sensitivity across the group. Obviously, for a screening tool, having high specificity is beneficial. The accuracy was fairly high also. And the area under the curve had some variability, but was definitely highest between the decision tree and ensemble domains. One might be asking themselves, well, 77%, you know, that leaves 25% kind of gap. And this is true. However, when we look globally at the screening tools that are currently being used across urology, PSA, for example, when we go look at what the area under the curve for those is, it's around 75%. And you might be saying, well, PSA is antiquated. It has, you know, it has its own set of problems. And I would agree with you. However, even some of the newer kind of targeted testing for prostate cancer and bladder cancer have similar areas under the curve. So this is all saying that even with these somewhat low numbers in terms of global machine learning ability, these are still fairly promising results. This is just a visual of that area under the curve. I broke down earlier that there was a 5-point cross-validation. So anytime we rerun the data, we get slight variations in the area under the curve, which is what you kind of see here. And that is the real advantage to machine learning above other types of statistical analysis. It can have real-time changes with addition of information, with re-looking at it constantly. So it can grow with our patient population, which is really the future. Again, this is just a breakdown of true positives, true negatives based on the results. So to kind of round things out, there are some limitations with the study. As mentioned, it's 229 patients. That's fairly low for a machine learning model. However, as a first evaluation, these results are very promising. And it has the advantage that we'll be able to compare it against, we could potentially compare this against other data sets to confirm generalizability, and it can continue to potentially act as a real-time learning model. But at hand, it's a machine learning model that is the first steps for us having a more risk stratified approach for evaluating who would most benefit for undergoing a microscopic hematuria evaluation. Thank you for your time.